way activated for you this week then, I guess. Okay, so last time we were talking about the little tool, which I call the autonomic trick. And so that brings us to our category of direct acting sympathomimetics. And as we were talking about before lunch, the direct acting sympathomimetics are parallel in one context with the direct acting parasympathomimetics, in that they all invoke for at least a significant part of their mechanisms of action, direct actions at various categories of receptors. So in other words, the neurotransmitters, hormones, or drugs are, in the case of the sympathomimetics, are directly binding to adrenergic receptors of the alpha and beta subtypes, all of which are G protein coupled receptors. We talked a little bit about how, in sort of an artificial sense, we selected epinephrine as the prototype, and that's not such a bad choice, really, in the context that when we think about stress response, and by the way, there's a very nice section on stress in Brain Facts. When we think about stress response, I think typically think about first the sympathetic side of it first, then the hormonal side of it with epinephrine second, and being regulated and triggered by the sympathetic side. So certainly to put epinephrine in here, it's really part of the ballpark anyway. And then, of course, in terms of longer range, more concerted stress response, we think about the glucocorticoids, and that's sort of a topic that we'll take on full blown next semester when we talk about the hormonal segment of our course in the very last few lectures of the year. Anyway, to help us more than anything else categorize adrenergic response, we sort of utilized epinephrine as the prototype here. Norepinephrine is, and there's a slide coming up on this, very similar in its pharmacology, other than that it has a somewhat weaker beta component. And not that the beta component is gone with norepinephrine, it's just not as powerful as it is with epinephrine. Epinephrine and norepinephrine are both very substantial cardiovascular stimulants. And that stimulatory action in the heart, it's mostly beta, not completely so, but mostly beta, and particularly beta 1 subtypes of the beta group of receptors. On the cardiovascular side, it's more complicated, and there are both substantial alpha and beta components on the vascular side. So, for example, alpha adrenergic vascular stimulation mostly is vasoconstrictor actions, whereas the beta component is a vasodilator action. And you might question this and say, well, why in the world would the system be utilizing both vasoconstrictor and vasodilator actions? Doesn't that seem kind of counterproductive? And it could be, except for the fact that there's organ level distribution differences between alpha and beta receptors. And so when you get a full sort of sympathetic activation like we're seeing here with Francis, we would like to see a sort of redistribution of his blood supply at this particular time to allow him to to get out of there, to fight, or to do whatever he has to do to survive. And part of the distribution, uh, redistribution of blood supply has to do with differential distribution of alpha and beta receptors. So I'm not going to go through the laundry list of it, but just to give a couple of examples. If he gets involved in a fight, he may suffer bites or scratches or some other damage to his periphery. And so one of the things that the sympathetic system does for us is that it shunts blood away from our cutaneous blood supply in our skin. So if we do get hurt in that particular sense, we're not going to just all of a sudden bleed to death. And another place where we like to have more blood is in our skeletal muscle. So, the sympathetic system does not directly regulate skeletal muscle. That's a non-autonomic function, but it does regulate blood supply to skeletal muscle. So in this slide that we're seeing here of Francis, very likely blood is sort of as rapidly as possible moving away from his periphery and toward his skeletal muscle anatomy, so that he can use that skeletal muscle to fight. So yeah, at first glance, that alpha beta sort of differentiation as far as cardiovascular system is concerned seems to be a weird thing, but it really has a reason for it, seemingly, in terms of trying to sort of second guess what's going on in terms of the battle plan that nature has designed from these particular functions. So the reason that I wanted you to take a look at the parasympathetic slide yesterday was that, of course, we're seeing just the opposite thing here, whereas the parasympathetic slide says cardiovascular depressant. Here on the sympathetic side, it says cardiovascular stimulant. And down on GI, gastrointestinal and urinary function, see gastrointestinal and urinary activation on the parasympathetic side, and depression on the sympathetic side. So once again, going back to our great buddy Francis, urinary and gastrointestinal function don't mean anything to him at this point. If he doesn't survive the attack or whatever is going to occur, he's not going to need to assimilate nutrients anymore or eliminate waste products from the system. His system needs to pay attention to those focal elements of just the few seconds or minutes that the attack is occurring, and that's not the gastrointestinal and urinary systems of great importance in that regard. So the next line down is kind of another one of the exceptions. If you go back to the parasympathetic system, take a look at our textbooks or at the physiology book, for example, you don't see much there with respect to the metabolic system, other than, of course, that the parasympathetic side is bringing nutrients into the system and storing them. But in terms of diminishing metabolism, it doesn't really do that. So the sympathetic stimulation of metabolism sort of stands alone, but it's a very, very prominent effect. So you see increased utilization of oxygen, which of course suggests that the oxygen is being used for oxidation of carbon in the system, such that the carbon can be further catabolized, ATP can be formed, and ATP can be used for the stress response, which is so in need of energy input at that point. So by learning about parasympathetic system, you don't really learn about the metabolic side of it here on the sympathetic deal, which then is one of the weaknesses of my idea of saying, well, just learn about the parasympathetic system and then you've learned it all. Well, you haven't quite learned it all, unfortunately, because there are these exceptions that occur. So metabolic stimulation is a very prominent sort of thing as far as sympathomimetics are concerned. And you especially see it with respect to epinephrine itself, because again, epinephrine has that very strong beta component. And for example, one significant beta action is with beta 3, which is the prominent distribution of beta receptors in fat. And so you're going to see mobilization of carbon from storage in fat, and utilization of those carbons for catabolic purposes. So anyway, that's a big deal, metabolic stimulation with adrenergic agonists. Now, I'm not sure I listed it on the slide, but I certainly could have listed bronchoconstriction from the standpoint of the parasympathetic side, and of course the opposite effect, bronchodilation, in terms of the sympathetic side. Makes a lot of sense, I think, in terms of the sympathetic side. If you're under threat, you need to, of course, bring more oxygen into the system. You need to breathe faster and deeper, and the bronchodilation effect maximizes that particular thing. That, of course, is also utilized significantly in therapeutics, in that the B2, beta 2 bronchodilator actions are very significant components. And Kevin talked about this quite a bit, I think, in his lecture on the autonomic pharmacology and related effects in the lungs. So if you look over on the parasympathetic side, you do see the counterexample. You do see bronchoconstriction, but it's not as prominent a thing as the dilator action is over on the sympathetic side, although it's prominent enough to be problematic in individuals who are sensitive to bronchoconstriction. So you'd say, well, what use is it then? Why is the bronchoconstrictor effect put in there for the parasympathetic side if it's really not useful? And I think I don't really know an answer to that question. I just sort of toss it out there. But I think it's because the parasympathetic system is a energy conserving sort of system in the sense of bringing nutrients in and not wasting any extra energy. So when you don't need to be devoting yourself to bronchodilation in the lungs, just on a normal function, just like you are right now, for example, but perhaps you've been at that dilation phase, the bronchoconstrictor thing just brings the system back to homeostasis. And it doesn't need to be super powerful in terms of doing that, but it's just a reorientation phenomenon that balances out the system. That's my guess anyway, but that's just a guess, and it could be wrong. But to think about both the bronchoconstrictor effect on the parasympathetic side and the bronchodilator effect on the sympathetic side is certainly a fairly useful thing to do. And again, especially with respect to sympathomimetics in the drug world, that's a real prominent sort of deal. So this, excuse me, next slide, entitled Other Sympathomimetics, is where we were a few minutes ago, really, when we were talking about the effects of agents in terms of appetite suppression. So the prototypical agent now becomes norepinephrine, because the other sympathomimetics has a very prominent sort of alpha flavor, at least the first agents that we're going to talk to, alpha flavor to it. So, norepinephrine can be utilized as a prototype in this particular arena. And again, all you need to do to think about what these effects are is think about epinephrine and then just pull back on that beta side a little bit. Not eliminate it, but just pull back on it a little bit. And you have what's going on with norepinephrine. So, it's very prominently alpha with a sort of a weaker subcomponent of beta. Now, agents like phenylephrine, which is a classic pharmacological agent in its own right, are all alpha or almost completely all alpha. To get absolute complete alpha beta separation may be somewhat difficult, but typically phenylephrine is thought about in terms of its nearly pure alpha effects. So if you think, what does that mean in terms of the pharmacology? Again, go back to epinephrine and now subtract the beta component out completely and just stay there with the alpha component. So in the vasculature, for example, when the beta is gone, you don't have that vasodilator effect. You just have the vasoconstrictor effect. So alpha agents, including norepinephrine, but especially all alpha agents like phenylephrine, are extreme vasoconstrictors and elevate peripheral resistance and blood pressure dramatically, which can be very useful if an individual is hypotensive, but can be very dramatically negative in individuals who are hypertensive or who are extremely sensitive to that alpha effect. So that's a clear distinction. And if you go back to epinephrine again, and you take a look at a blood pressure tracing, and I know Goodman and Gilman used to have these in it. I think it still does. But if not, let me know and I'll find a tracing for you. It's very interesting to note that, especially in some individuals, epinephrine is not all that hypertensive because you get, alpha and beta effects. But if we go to norepinephrine and phenylephrine, especially, you see a very distinct and prominent elevation of blood pressure there. So some nice comparisons that you can make between epinephrine, norepinephrine, kind of in between, and phenylephrine and its analogs on the alpha side. Now, next on the slide, you see indirect acting sympathomimetics, such as ephedrine and amphetamine, which we were talking about a little bit earlier. So this is where this sort of difference in meaning indirect relative to over on the parasympathetic side. Remember, indirect acting there meant that you were invoking a mechanism of action involving another whole site of action, the acetylcholinesterase. And as acetylcholinesterase was inhibited, then of course acetylcholine built up in synapses. And the ultimate direct action then was from acetylcholine, but you had to have that indirect action first before you had extra acetylcholine in the synapses. In the sympathetic system, indirect acting refers to the increased. There can be a number of components to it, but the most prominent one typically is increased release of norepinephrine from synaptic locations by ephedrine, amphetamine, methamphetamine, or that whole group of psychostimulants there. So it's a little bit different flavor in terms of indirect action than what we saw back on the parasympathetic side. Now, you might ask the question as you proceed through the slide, or maybe you have already asked it if you have looked at this previously, or perhaps you know it from other things you've learned. Are there agents which are all beta, or pretty much all beta in terms of their pharmacology? And of course, the answer is is absolutely there are. And, the classical prototype in this realm is isoproterenol. Um, and isoproterenol is, non-specific. There's some challenges with terminology here. It's a specific sort of substance in the sense that it well differentiates between alpha and beta. It's non-specific in the sense that it doesn't differentiate between beta subtypes well. So in other words, isoproterenol, activates beta 1, beta 2, and beta 3 receptors, all with pretty substantial efficacy. Now, as useful as all beta agents can be because of their prominent beta actions, um, the full milieu of beta effects may not be always what you want. So I gave an example of a reasonably selective beta 2 adrenergic agonist in albuterol. And people are probably familiar with albuterol. It's still, despite being used for quite some time, it's still a very prominent drug in terms of producing bronchodilation. And, where you would like to have some selectivity there, and you do have some, although not complete selectivity, is that an individual that is seeking the bronchodilatory action may also be sensitive to heart-related beta effects, and you don't want to do that overstimulation. So isoproterenol would stimulate both heart and bronchial smooth muscle, whereas in beta 2 selective, relatively selective agent like albuterol, it has many fewer effects as far as the heart is concerned, but maintains that that reasonably selective aspect of beta 2. And the discovery of relatively selective beta agents like this was another one of those hallmark sorts of events in pharmacology that really advanced things forward, and a very clear example of where specificity is important. Now, specificity is not always important. Sometimes having agents that cross various sorts of sort of receptor boundaries, such as like we were talking about with cannabinoids the other day, whereas that may not be useful there. In the cases here of the adrenergic system, it's very much a useful sort of thing. So now moving on, how are we doing on time? Are we about done with time? Anybody have a watch on or see the time on their computer?
It's a 1:47.
1:47. So we're almost done. Let me just say that, of course, having done agonists, now we're heading to the realm of antagonists, and we'll start with that in the morning, or not in the morning, in the afternoon tomorrow. But before I say anything more at all, let me just see if there's any sympathetic related questions, sympathetic agonist related questions that anybody would like to ask before we break until tomorrow afternoon's lecture at 1. Sympathetic system, any questions so far? Okay, everybody. Well, thanks for your attention and patience, and hang in there with all the busy week things that you got going in front of you. And if need be, file back into our slides here a little bit and get a little relaxation by looking at some of those pastoral themes. Okay, take care. I'm going to stop. See you soon.